people that will join, which is totally fine, but let's get started. Welcome to the Fellow Lecture Series for 2025. I'm really happy to be here today. So thanks, Mike, for inviting me back. My name is Liz. I am the GI oncology pharmacist at UW. So I practice within our ambulatory clinics with our MedOncs and wonderful APPs. If there's ever any questions, full disclosure, always feel free to contact me, especially if you get a GI patient, either that's admitted or even if you have some tricky immune checkpoint inhibitor toxicities. I'm always willing to kind of help out in those situations. So with that, let's get started. We got a lot of material. I got 30 minutes to cover both. We're going to cover a lot of basics, but I always like to leave these lectures with pearls and kind of practice things to consider when you're taking care of these patients. So let's get started. So our objectives are listed on the slide here. Again, we got about 30 minutes to devote to GI targeted therapies, and then about 30 minutes to devote to immune checkpoint inhibitors. We'll talk about mechanism of action, some dosing, and then side effects, and then kind of like the Liz pearls for supportive care and management for these patients. So let's jump in first with panitumumab and cetuximab. So these agents bind to the cell surface epidermal growth factor receptor, and it prevents that EGF and TGF binding, and therefore that signal transduction cannot happen in the cell. Now, historically, these were used in colorectal cancer space, and they must be KRAS wild type. So they must have wild type for that. They can't have the mutation. Small change this year, and we'll get to that slide coming up. The biggest things with panitumumab and cetuximab is there is an infusion-related reaction risk, more so with cetuximab, and there's going to be pre-medications from that versus panitumumab. In the GI cancer space, we are more predominantly a panitumumab institution. This kind of was set in stone prior to me starting here over 9 years ago. The biggest things, though, with both cetuximab and panitumumab is the acneiform rash risk. We're going to talk about that a little bit more. And these two are culprits for wasting magnesium. And I mean magnesiums less than 1 can happen for patients. Now, this acneiform rash, so this is actually the most common side effect. It affects at least 3/4 of patients. So this can be very, it has a high morbidity for patients, right? They look like they are back to being 13 years old. It looks like acne, but it is not traditional acne. So it's always really important to educate patients. We don't want you treating this like acne. We don't want you drying it out. As you can see, it has like papules and pustules, especially the T-zone of the face, but essentially it can happen anywhere on the body. And patient education is crucial for this. In addition, though, to acneiform rash, patients can develop other toxicities over time. So as you can see by the picture of the eyelashes, patients' eyelashes will kind of grow to be really long and kind of curly and wiry. Most often, patients will have to trim them. It's always interesting when we've had a patient on panitumumab for many months and then they come back in to see like their eyelashes and then their hair. It can almost become like kind of kinky, almost like a crimper from the 80s, if anybody remembers that. In addition, patients can develop these painful lesions on the sides of their fingernails. Not a lot that we can do for that sort of thing, except for using moisturizers and protecting those tissues. Now, I don't have, a lot of times in cancer care, we don't always have a lot of really good supportive care trials. I always try to highlight them if we do. This one is a really big trial. So the STEP trial, it's an oldie, but still a goodie. It essentially supports our how we try to prevent this acneiform rash. So when patients start on panitumumab or cetuximab, they will be given preemptive approach, meaning moisturizing their skin. In the morning, it's recommended to use an SPF on their face, topical hydrocortisone cream at bedtime, and then they actually start on oral doxycycline, continuous. They did it for at least 8 weeks in the trial. Honestly, we keep patients on this for however long they're on the therapy, as long as they're tolerating it, because we know acneiform rash is something that can wax and wane. We also know why the SPF is important is that it can occur or get triggered by UV radiation. And I always like to use the example. I had a patient who was a truck driver on panitumumab, and his left forearm was the only place that had rash. And that was because that was the arm that was up on the windowsill. And once he used sunscreen, it kind of resolved. Now, acneiform rash is something that waxes and wanes. I think some patients might get a flare up beginning and then things get better, but then it can flare up again. And so those are important points to discuss with patients. Now, health facts for you. This is available through our system. You can search this. It's about 3 pages, but it contains a lot of like tips and tricks for what patients can do at home, and what like sort of moisturizers they should be using, or what things that they should avoid. Now, I mentioned that this therapy is used in combination for patients who are KRAS G12C mutated colorectal cancer. So this has been an update in the past year. So our 2 combinations, adagrasib plus cetuximab and sotorasib plus panitumumab. I don't think you guys have had the lung lecture yet, but adagrasib and sotorasib are approved in those settings. They're now approved for KRAS G12C mutated colorectal cancer, which is exciting. Side effects are listed here. You essentially get the pani or cetuximab reactions, then plus adagrasib and sotorasib side effects. So, I do have a handful of patients on this. Electrolytes can still be an issue, diarrhea, fatigue. Seems to be a little bit more nausea risk with adagrasib versus sotorasib. Kind of currently encountering that in clinic, but again, you're combining 2 therapies. You're going to almost get double the side effects from this regimen. Okay, let's move on. Capecitabine, it's an oldie, still used in a variety of different settings, from the GI cancer space even into the breast space. So capecitabine, as a pharmacist, we always geek out when something's a prodrug. Prodrug meaning once you take it orally, it gets converted in the patient's body to 5-FU. If you think about 5-FU, we give that as a bolus and a continuous infusion. Now, in terms of capecitabine, oral drug, your patients have to be able to take oral tablets. Biggest side effects are going to be hand-foot syndrome. I'm going to talk about hand-foot syndrome coming up. Diarrhea, especially towards the end of a cycle. So most common cycles are days 1 through 14 of a 21-day cycle. Towards days 10 through 14 is when that diarrhea tends to occur. Of course, it's rare, but diarrhea can occur in the first couple days. Capecitabine can be combined with some IV therapies, so like oxaliplatin, for example. And sometimes this could be used in the radiation setting, meaning it's used as a radiosensitizer. Now, hand-foot syndrome, what is this? So it is a toxicity from capecitabine and continuous infusion 5-FU, in addition to Doxil. So that's another IV chemo agent that can cause hand-foot syndrome. So it's quite variable. It's not always a side effect that occurs immediately, but more with continuous dosing. What is it? It's dryness, cracking, peeling, redness, palms of the hands, soles of the feet. We know the number 1 way to prevent this is going to be moisturization. So I always love when I get my, older patients, especially males, who maybe have not moisturized at all in their life. And then I'm telling them where to go in a store to purchase moisturizers because I'm going to need them to moisturize their hands and feet. Now, Cape Care updates, these are a couple things. So we do recommend for cycle-based capecitabine, so not capecitabine that's used with radiation, to use topical diclofenac to help to prevent hand-foot syndrome. So what patients do, and kind of how it's like a trigger and how I do teaching, right? So capecitabine is dosed twice a day. I usually say, you're going to eat your food, you're going to take your capecitabine, you're going to wash your hands, and then you're going to apply a pea-sized amount of topical diclofenac. Now, topical diclofenac is available over the counter. It's known as Voltaren gel or cream. There's 2 different formulations. It doesn't matter what to get. Some insurances will pick it up. I don't have a ton of success with insurance covering it, but otherwise patients can pick this up over the counter. So pea-sized amount, palms of hands, soles of feet. Let it absorb 1 to 2 minutes, and then apply a bland moisturizer over top. I usually do more lotions and creams during the day for patients. And then after those 2 times at bedtime is when I have patients use topical emollients to kind of lock in that moisture overnight. Some patients will get the white cotton gloves. Some patients will get, put their socks on after. That's beautiful. Other things with capecitabine, especially in a metastatic setting, is changing how we give the dose. Meaning, yes, our most common cycle is a 21-day cycle, 14 days on, right? We have found that when you switch to 1 week on, 1 week off, patients tolerate it better. And even in this data that was presented at ASCO, I think it was in either 2023 or 2024, it actually shows that this 1 week on, 1 week off is still actually efficacious. So they're finding there's less hand-foot syndrome with 1 week on, 1 week off. And it is something to consider for patients if they're really struggling with that hand-foot syndrome. Again, we have health facts for you. I think this is a really great handout to give patients just so that they have something physical at home for the hand-foot syndrome. Okay, let's move on to bevacizumab and ramucirumab. So bevacizumab is used in a variety of different disease states, right? It's used for brain cancers, colorectal cancer space. Ramucirumab is also has a couple, but we really only use it most commonly in the gastric cancer population here at UW. It was almost like a Me Too drug, 5 to 10 years later after Bev came out. Bevacizumab also has biosimilars, which is really nice, which can, of course, help to reduce costs. How this drug works, it binds to vascular endothelial growth factor ligand, and it prevents that ligand from binding to the receptor. So if it can't, I always like to think, and that picture is beautifully shows it, if that tumor can't grow its vasculature, that means it can't get more nutrients to grow. So it almost stabilizes it, and maybe sometimes in some settings can shrink it. With affecting vascular endothelial growth factor ligand, if you think in the body, the vasculature, that's where you can kind of think of where side effects come in. So I always say to patients, think of clotting. So you're at a higher risk of blood clots, but at the same time, you're at the higher risk of bleeding. In addition, it can cause hypertension. It's usually not a hypertension. The patient usually does not go hypertensive within one dose. That's not usually how Bev hypertension happens. It's more with continuous doses, and you might see their blood pressure just slowly increase with more Bev doses that they're getting. Now, what to do if this happens for a patient? Depending on the value, most often you can start an antihypertensive, send them back to the PCP to get some management, and resume bevacizumab once it is back to within normal levels. It does not mean that patients cannot get this therapy anymore, just FYI. So now we do monitor blood pressure. We will not actually prepare the product until we see what the patient's blood pressures are. Patients need to be held around surgical procedures. So being, forthcoming with patients, if you're on any sort of procedures planned down the road, we need to know about that. And then the signs and symptoms of bleeding and clots. Very interestingly, ramucirumab actually has an increased reaction risk. So that, or you'll see in the treatment plans that patients will get pre-medications prior to, versus bevacizumab, we don't have to do pre-medications. Lonsurf, this is when I think of drug names, this is a very unique drug name. I don't know where they got it from, but what it is, it's trifluridine and tipiracil. Trifluridine is a thymidine-based nucleoside that interferes with DNA synthesis. Tipiracil actually is a phosphorylase inhibitor, and it increases trifluridine exposure. So that's not actually the active chemo agent. It just helps to increase trifluridine exposure. Dosing is unique. So the FDA package dosing is 35 milligrams per meter squared twice a day on days 1 through 5 and 8 through 12. Now, this dosing regimen is not well tolerated at all. Probably 5-ish, 6-ish years ago, myself and Dr. Deming we adjusted the dosing to do days 1 through 5 and 15 through 19. That is listed in our treatment plan. We actually, not to toot my horn, but we actually did publish this data. Patients actually tolerate it better, and they're able to stay on therapy longer with less treatment interruptions and actually have better outcomes. So in our population, we combined it with Vanderbilt. It was actually really cool to see that. The days 1 through 5 and 8 through 12, it's almost so fatiguing that first week after day 12, patients feel miserable. And so when we split the dosing and did it every other week, patients actually tolerate it better with less fatigue. Now, data in the colorectal cancer space, again, this agent is approved for like third line and beyond for colorectal cancer. You'll often see it combined with bevacizumab, so that does have better patient outcomes. And it's nice because then it aligns with bevacizumab that's given every other week. So data to support it, consider using it if you have a patient. Now, typical side effects, there's an infection risk, nausea and vomiting. Very interestingly, like in the trials, it reported like a low risk. It's more moderate to high. And if you think the patient's been exposed to a lot of therapy previously, that can affect it too. And then, of course, diarrhea can happen. Okay, shifting into multi-kinase inhibitors. I am not going through all the NIBs that can be approved in the GI cancer space. I'm going to highlight a couple and different little nuances associated with them. You will hear probably some of these NIBs in different settings, which is common because some of these agents have multiple indications. But let's jump in. So these multi-kinase inhibitor, tyrosine kinase inhibitors, for example, we're going to talk about regorafenib first. This hits multiple kinases involved in oncogenesis and tumor angiogenesis. So it hits RET, VEGF, RAF, BRAF. Almost because it's a multi-kinase inhibitor, it has a lot of side effects. Regorafenib, when I see regorafenib, especially used in the colorectal cancer space, it's like painful for me because it's not well tolerated at all. So dosing of it, 160 milligrams by mouth once a day, days 1 through 21 of a 28-day cycle. Consider ramping. There's, I think it's data from the VA population where starting with 80 or 120, because they come as 40 milligram tablets, and then ramping either every week or every cycle. So there's kind of different ways that you could do it. Patients actually tolerate it better. Sometimes the 160 right out of the gate, patients get socked with side effects. So diarrhea, fatigue, hand-foot skin reaction, hypertension can happen right out of the gate with the TKIs versus bevacizumab, as an example, that hypertension, not immediately happening. Now, in terms of settings that you could see this used in, I mentioned the colorectal cancer space. It's usually fourth line or beyond. Also can be used in HCC and GIST. Very interestingly, these patient populations, when I use it in my GIST patients, they seem to tolerate it better than the colorectal cancer patients. I don't know why. It's just, anecdotal. But yes, it can be used in all these settings. Now, fruquintinib got approved a couple years ago in the metastatic colorectal cancer space. It actually specifically targets VEGF receptors, so a little bit more specific compared to regorafenib, where there's a lot of different targets. This one, 5 milligrams once a day, days 1 through 21 of a 28-day cycle with or without food for patients. Only approved in the CRC setting right now. Very similar side effects, hand-foot skin reaction, diarrhea management, hypertension, and so forth. Interestingly, this one can cause, and actually most of them can technically cause voice changes or hoarseness. So it's really interesting where after a couple months of therapy, patients will like my chart us and say, my voice, it's a little deeper or huskier. And it's like, oh, it's probably from the drug that you're on. Not super common, but it can happen. Unfortunately, there's nothing much that we can do about it except stopping the drug. Now, in terms of that dosing, I have yet to have a patient tolerate 5 milligrams. Most often, patients will either land at 3 or 4 milligrams daily. It just can be a lot, especially given these patients are heavily pretreated once they actually get to this agent. Cabozantinib. So this one, 60 milligrams by mouth once a day on an empty stomach. The empty stomach can be problematic for some folks. Sometimes if it is problematic, I'll say to patients, maybe consider taking it with 1 to 2 crackers, and that's totally fine. Settings that it's indicated for, HCC, GIST, and finally, neuroendocrine tumor. That only took many years. The trial was finally published and the FDA finally approved it earlier this year. So you can use it for PNET and NET patients. This hits a lot of different receptors, which means a lot of side effects. So kind of like regorafenib, although I think patients have better tolerance to cabozantinib. Anyways, side effects, hand-foot skin reaction. We're going to talk about how to manage that coming up. Hypertension, diarrhea, fatigue. As you can see, all the nibs, very similar side effects, and it'll make it easy when you're classifying or teaching on nibs that you'll know that bucket of side effects to teach patients. Finally, sorafenib. This used to be the gold standard for treatment of patients with HCC. We've come a long way for treatment of HCC now, so it's definitely shifting down in terms of when we'll go for it. This is a drug, it's dosed twice a day on an empty stomach. This one you should also ramp, just like the regorafenib I would recommend, just to get better tolerance. Again, HCC setting and GIST, very similar side effects. It hits a lot of different kinases also. So as you can imagine, and for teaching purposes, I know there's a lot of drugs that get thrown at you in these lectures. Nibs, you can kind of think that they are going to have very similar side effect profiles, which is what I highlight here. It makes it easy, right? And even when I'm teaching pharmacy residents, how these drugs work is going to help you to understand what the side effects are, and then you can bucket them for patients. We have beautiful handouts that we use for patients starting these oral nibs, but big picture, that hand-foot skin reaction, hypertension, fatigue, the GI system, nausea, vomiting, diarrhea can all happen. Some affect more, thyroid versus others. It really just depends on the agent, but at least you'll have that bucket of side effects to review for patients. Okay. Interaction here, guys. Let's talk about skin toxicity. So in this the farthest left photo, the guy's feet, top of his feet, what is this? This side effect, when it's this redness and inflammation, and especially those like darker toes, that is from taxanes. So like docetaxel and paclitaxel. Very interestingly, we just had a patient who is undergoing FLOT treatment, which has docetaxel in it, and the surface of his hands are all red and rashy. That is a classic side effect of taxanes. Not a lot you can do, but you can try some topical steroids and reducing the dose. Thankfully with FLOT, it's kind of a finite amount of taxane that they'll get. We usually can work through it. The middle picture, this one is the hand-foot syndrome. So that dryness, cracking, peeling, redness in some areas is really from your capecitabine, your 5-FU, your Doxil. The farthest right photo here, this is that hand-foot skin reaction. It is distinct from hand-foot syndrome. Hand-foot skin reaction is more calluses and more blisters. So as you can see on this foot, you can see the areas that are calluses. That is from the multikinase inhibitors, and you treat it differently. So with that, and when you're educating patients on nibs and how I educate patients, if there's moisturization is going to be your friend, making sure you're keeping your skin as moist as possible. If there's any calluses that develop, you can use urea cream. There are some urea creams over the counter that'll help to break down that tissue. In addition, they can get pumice stones and kind of like grind down those like pressure points that most often that develops on. And then if it's really severe, if it's blisters, most often we're holding and then dose reducing. I do tell patients to keep an eye, especially on their feet, if they're noticing, oh yeah, it's a little painful on the bottom of my foot. They might have a blister or at least a redness or sore happening from their TKI. Okay, let's move to pemigatinib and futibatinib. Fun fact, I love saying futibatinib. These are indicated for FGFR2 genetic alterations for patients who have cholangiocarcinoma, which is amazing. So we have two agents that we can use in this setting. So pemigatinib was actually the first on the market. It's cycle-based, so 13.5 milligrams by mouth once a day, days 1 through 14 of a 21-day cycle, with or without food, so that doesn't matter. Now, these agents, and why I like to highlight them, is because they can affect phosphate. They can cause phosphate elevations even within the first cycle. So what do we do for those patients? Package inserts are pretty clear. You got to insert a phos binder, just like the phos binders that we use for patients on hemodialysis, and monitor it closely. They also can cause ophthalmic changes or eye changes. And so patients actually do need ophthalmic evals at baseline. And then just depending on the agent, the follow-up based on that. Usually once we get a patient connected with an ophthalmologist, they know how to follow and they'll follow patients closely and will give us results if there's any issues. Other things that can happen, nail changes. It can become, it's really, oh gosh, when you see a patient who's been on pemigatinib or futibatinib for a while, it's almost like their nails are starting to disconnect from their nail bed. At that point, we are usually sending them in to see Oncoderm. Oncoderm, we have really great oncodermatologists here, so get them in to see them. There's not a lot you can do except holding drug. Taste changes can happen. Mouth sores can happen. Right now, in Dr. Kratz's clinic, we have a patient with pretty significant mouth sores from pemigatinib. We've done some dose reductions, and now we're doing a lot of different mouth washes. Trying to keep the patient on therapy, of course, because he's actually having a good response. But futibatinib, in contrast, is actually continuously dosed, which can be easier for some patients, especially if adherence might be a concern. With or without food, also, insurances are sometimes dictating what agent we might get to use out of the gate, which is frustrating. These two have never been compared head to head, so we don't have that data. Now, these drugs work by hitting the FGFR. It's a kinase inhibitor, and then all the downstream effects can't happen, and then the cell can't survive without that. Ivosidenib, I like to highlight this one. So it originally came on the market for AML, for IDH1 mutated AML. I'm pretty sure it's AML. I am blanking on that. But anyways, we do use it in cholangiocarcinoma, so patients that are IDH1 mutated. This agent globally, and I don't get to say this a lot about a lot of agents, it's actually pretty well tolerated. We've had some patients have some really long-lasting a lot of months, even years on therapy, which is amazing to see. So if the patient has an IDH1 mutation for cholangio, this would be indicated and you could start a patient on it. It's continuously dosed with or without food. It is a small molecule inhibitor of IDH1 enzyme, that mutated enzyme. Again, biggest things with this, especially out of the gate, can be some changes in electrolytes. Patients do have to have ECG monitoring prior to therapy more frequently out of the gate. I can say I've had patients, ECGs, especially their QTC, get prolonged, and we've had to hold therapy and reduce dose. So for a drug to have this happen, this agent can do this. So just know that. Other things with this, some nausea and diarrhea, but once patients seem to be on therapy a couple months in, it's usually, knock on wood, smooth sailing. So usually there's not any late side effects associated with this one in the cholangiocarcinoma population. Now, zolbetuximab, exciting. This got approved last year in combination with FOLFOX or CAPOX for patients with gastric cancer. They have to have claudin 18.2, a certain percentage of it, to qualify for this agent. Very interestingly, so it's combined with IV or oral chemotherapy. It is given on those days. This agent will be given first in the treatment plan. There is a pretty significant risk of nausea and vomiting within the first 2 cycles. So we do, and how the guidelines, NCCN guidelines, are listed out for emesis, it is a high risk regimen. Sometimes you can reduce things over time, some of the meds, but within those first 2 infusions, it can be pretty terrible. And it's usually immediate nausea and vomiting. Now, something that I will get questions on from infusion center nurses, when patients start having this nausea and vomiting, they think it's an infusion reaction. It is not. This is actually just an off-target effect of this because of in the gastric lining, there's a lot of these receptors, and they're thinking within the first 2 cycles, this all gets ramped up, which is what triggers the nausea and vomiting. It's a cool agent. I think zolbetuximab is going to be the first of many different claudin-targeted therapies. We have a few clinical trials right now which is amazing. Studying agents that work very similar to this, slightly different, but pretty similar. And they do have this nausea and vomiting risk. So it looks like it might be a class effect. Anyways, your patients could qualify for this, your metastatic gastric cancer patients. Okay, right on the dot. It's 8:30. We're moving to immune checkpoint inhibitors. So not globally all immunotherapies, right? I only have 3 minutes, guys. We are going to focus on CTLA-4, PD-1, PD-L1. I will never forget when ipilimumab, so your CTLA-4, was first approved in 2011. Using it in the metastatic melanoma population when I was a pharmacy resident, and seeing the outcomes was amazing. And then fast forward, of course, we have a lot of PD-1 inhibitors, a lot of PD-L1 inhibitors, and now a LAG-3 inhibitor. Super cool to see immune checkpoint inhibitors have revolutionized the treatment of many different types of cancers and different disease states, and honestly have significantly improved patient outcomes, which is so cool. Anyways, this reference here and this website is a really good tool. I'm pretty sure if you just like Google pembrolizumab, this actually website pops up. Why I like this website, and it's kept up to date pretty well, is because it'll contain what immune checkpoint inhibitor or what immunotherapy, when it was approved, what setting it was approved, and then the data that supported that specific indication for the FDA. So it's a really good, like, if you're like, oh, why is pembrolizumab approved in this setting? You can go to this website and see it. So really cool reference to have in your back pocket. Now, how do these drugs work? CTLA-4, PD-1, PD-L1. When I explain to patients in very simple terms, cancer cells find ways to turn off their immune system, right? We have discovered ways to turn the immune system back on so that we can see those cancer cells. Our immune system can see those and then fight them. Way back when, I used to use a Harry Potter reference. I think it's outdated now because you guys are younger than me. But essentially, it's like the cloak of invisibility. And we're removing that cloak of invisibility to see those cancer cells, and the patient's immune system can be active in that setting. Now, globally, these therapies are pretty well tolerated. The focus of my presentation today is going to talk about how we monitor them and how we treat different side effects and the resources available. Now, there's a couple different guidelines, but in terms of monitoring, we have tried to build our treatment plans, our beacon treatment plans, with immune checkpoint inhibitors similarly, so that we are monitoring the same thing relatively in each treatment cycle, if it's pembrolizumab used in the colorectal cancer space versus the non-small cell lung cancer space. So the treatment plans are built similarly. All of the labs are built within those treatment plans. So, the TSH, free T4, cortisol, LFTs, and so forth. They're all built within those treatment plans of how we want those monitors. If you're ever wondering where we might have gotten our recommendations from, the bulk of them come from NCCN guidelines. They have these really beautiful charts that show you what to monitor, how often, or if symptoms are happening for a patient, what to consider monitoring if it's happening. So, for example, I like to call out musculoskeletal pain. It's the last box. There's no routine monitoring done for these agents. But if a patient is starting to have symptoms, you can get a CRP, ESR, or a CK for those patients just to see if something's going on. I've seen that happen in practice. If it's something where, our therapies aren't working or our steroids aren't working, getting rheumatology involved also if it's more of a tricky situation. I think with immune checkpoint inhibitors, we have to use our multidisciplinary colleagues, right? So rheumatology, pulmonology, if you're having a pneumonitis sort of situation, GI, oncodermatology, using our experts in these fields is going to be crucial, especially if you have a more severe side effect picture for a patient. So talking about history, way back when in melanoma, right, because this is the first setting that immune checkpoint inhibitors revolutionized the treatment of, we had IL-2. I will never forget witnessing a patient get IL-2. It is essentially giving gas or throwing gas on the immune system. So I like to see in my mind, it's this like big flare up of fire that happens. Patients need to be in an ICU setting for IL-2. I'm giggling because it's like, how awful was that for these patients that I witnessed? They get capillary leak syndrome with hypertension, myalgias, diarrhea, liver toxicity pretty quickly. 85% of patients get that. Why science matters, we started to understand the immune system better, and then we got better targeted drugs, right? So CTLA-4 was the first agent, so ipilimumab, on the market. About 26%, so a quarter of patients had grade 3 or worse toxicities. Now, ipilimumab and this number, it's kind of it's interesting just based on ipilimumab dosing. Some doses are 3 mg per kg. Some doses are 1 mg per kg. Way back when there was a 10 mg per kg, guys. Nobody uses that anymore. But dose seems to matter with ipilimumab in terms of the percentage of side effects that happen. Then we got even better. Then the PD-1 inhibitors, nivolumab and pembrolizumab, came on the market, indicated in this setting, less risk of side effects because we're getting more specific to the T cell and the T cell and the cancer cell. Then we combined CTLA-4 and PD-1, right? Ipilimumab plus nivolumab. That's used in a variety of different settings, not just melanoma anymore. It's about half of patients will get a grade 3 toxicity at some point in time. And then fast forward, the latest is a PD-1 plus a LAG-3. How I think of LAG-3, when I see LAG, I'm thinking of a tired T cell, and it essentially works by like energizing. So like kind of like caffeine. About 40% of patients will have a grade 3. So as you can see, you add agents, the risk goes up with that. Now, educating patients. The biggest thing I see in clinical practice is that we don't always highlight the risks of side effects with patients because most often patients feel no different when they start this therapy, which is amazing, or they might have minimal side effects, but there is a significant risk, right, of a grade 3 reaction. And so I highlighted here, I took a screenshot of the NCCN. You can find this, Understanding Immunotherapy Side Effects. So we'll use this within our GI cancer clinics to give to patients that are started on immune checkpoint inhibitors to showcase what side effects to watch out for. Now, it's always a balance, right? You don't want to scare patients, but I like to tell patients, I just want you to be informed of what to watch out for. As you're going through your careers, you're going to experience some significant immune checkpoint inhibitor toxicities. You likely won't forget some of those first initial really bad ones. But I always say upfront patient education is important. Us as clinic pharmacists, all patients that are started on immune checkpoint inhibitors get a wallet card. It's about this big. I giggle because some patients look at me like, I can't put that in my wallet. So I say, fold it down, fill out your emergency contact. That's important because, say 6 months down the road, they're feeling great, they take a trip somewhere, and they break out in a full body rash, and they have to go to a local ER. I always say, patients, you have to show that urgent care, emergency room, even a PCP, that you are on an immune checkpoint inhibitor. A lot of times still, depending on that setting, when they see a patient has cancer, emergency department will think, oh, they must be on like cytotoxic chemotherapy, but that's not the case. So I think we're getting better as these agents have been out longer on the market. But I always say to patients, be your own person that's actually showing them what you're on so that those providers can kind of tie the picture together for the patient. So toxicities and agents matter. So this is a chart from 2015. It's now a decade old, but it's still a good one. So this one shows the typical timeline of when toxicities can happen from CTLA-4 inhibitors. As you can see in the picture, the rash plus or minus itching is the first side effect that can appear about a little after 3 weeks in, followed by the diarrhea and colitis risk. And as you can see, it kind of peaks and tapers off at around 10 weeks. Not saying it couldn't happen after, but these are really good for when you're trying to talk to patients about when to expect potentially side effects. Followed by that, we can see the hypophysitis and the liver toxicity risk. Again, all those the liver toxicity risk is built in your beacon plan, so we will be monitoring those closely. Now, looking at our PD-1 and PD-L1, so very interestingly, these came on the market. Yes, they have the same side effect risk of skin rash, less compared to ipilimumab. Same colitis risk, endocrinopathies, liver toxicities. But then we're noticing with the PD-1, PD-L1s, there is a risk of nephritis and pneumonitis that we really did not see from a CTLA-4 inhibitor. So that kind of changed how we monitor these agents. Now, the bottom left chart, when you combine ipilimumab plus nivolumab, you get all the side effects together and a heightened risk, right? Which is what I kind of showed in that melanoma data of like, once we combine the therapies, it's about a half of patients with a grade 3 or worse reaction. So how do we manage IRAEs? So we have clinical practice guidelines. I know this has been debated a little bit on our B66, our oncology teams. There are 3 guidelines available. You have NCCN. NCCN appears to be the one that is updated the most, not always as comprehensive. SITC also has a really great guideline. I'm finding some of the more rare side effects can be mentioned in SITC versus NCCN. And then ASCO. ASCO does have guidelines. I believe they are currently in revision, if I remember the last time I talked to Dr. Ma. I don't know when they're going to give an update. I think the last update for ASCO was in 2022, which we know the treatment of these IRAEs is rapidly evolving, rapidly changing. And so it's kind of outdated. It's still a good reference, but yet you might have better data in NCCN and SITC. Now, any of these side effects, you have to grade them. Typically, if we're looking at grades, typically grade 1, you can continue immunotherapy, just close monitoring for patients. Grade 2, plus or minus likely are going to hold it. Steroids, oral steroids might be used. Grade 3, hold, could potentially re-challenge. Usually you're going to connect with the multidisciplinary team on that. High dose steroids are used. And then grade 4, which is life-threatening. Usually we are not going to resume that immune checkpoint inhibitor, and high dose steroids are used. Let's go through patient cases. I picked out 4 different examples of IRAEs, some more common, some rare, just to kind of highlight different points. So first case, rash. So MJ, 66-year-old female, has metastatic melanoma. She presents to clinic prior to cycle 3. She reports she has a rash that's been increasing in size and remains extremely itchy. You look at her, she has a few scattered areas of rash on her upper chest, abdomen, arms, and upper thighs. About 15 to 20% of her BSA is involved. We know rashes are the most prevalent IRAE. Everybody's implicated, CTLA-4, PD-1, PD-L1. About a third of patients will develop a rash, regardless of tumor type. So it doesn't matter if it's melanoma versus colorectal cancer versus cervical cancer or so forth. Most common is a macular-papular rash. So that like red blotchy rash is what I tell patients. Sometimes patients just have itching, which is in the guidelines. So if you have a patient with just extreme itching, there are things that you can do. It's really important to have early recognition, because we know if we catch this at an earlier grade, we can get all the symptoms under control and then resume therapy. Now, grading matters and BSA matters. So grade 1, less than 10% BSA. Grade 2, 10 to 30. Grade 3, greater than 30. Grade 4, life-threatening. Any BSA. Now, based on MJ, who had 15 to 20%, what grade of toxicity is she experiencing? And let's see if I can pull up chat. Here we go. Yes, grade 2 by Beth. Thank you so much. She does have grade 2 toxicity. Now, what do we do for patients? So I pulled from the NCCN guidelines the current recommendations based on grades, so grade 1, 2, and then grades 3 and 4. For her grade 2, you're going to treat with topical emollients, some moisturization. oral antihistamines if she's itchy, and then a medium to high potency topical steroid. If they are unresponsive to steroids, then you consider initiating oral steroids. So kind of different compared to other disease settings. And as we've discovered more about derm toxicities from IRA or from immune checkpoint inhibitors, we've actually been able to reduce steroids. So it's a 0.5 mg per kg per day and then taper. As you can see, though, with a grade 3 or 4, it's a 0.5 to 1. If you get a patient that's admitted, I always say start with 1. You can always taper quicker. And then if there's no response, you go up to 2 mg per kg of high-dose steroids. Now, I included this chart here. It is readily available to find online if you search it, of the potency of common topical corticosteroids. FYI, hydrocortisone cream is the least potent topical steroid we have. If you're looking back at our patient MJ, a medium to high potency topical steroids, if you're looking at that, that's going to be betamethasone, fluticasone, and triamcinolone. That is the cream or lotion or ointment that she should use and be prescribed for that setting. Otherwise, sometimes people always go to hydrocortisone because they're used to it. We know it. 1% is over the counter, 2.5 is prescription. It's not going to do much. So making sure that you have the right potency topical corticosteroid for these patients. So what do we do for her? We held ipilimumab and nivolumab for a week. We started supportive care medications for her. So that triamcinolone cream applied twice daily, hydroxyzine as needed for itching. Patient did not like oral steroids, and so she did not want that at that time. And we followed up with her in a week. So she comes back. Her rash continued to worsen. She woke up with new facial edema, erythema everywhere. Approximately 50% of her BSA is now involved. The topical steroid really didn't do much. At this point, she gets an increase in her grade of toxicity, so she's now grade 3. So based on grade 3, what would be the best treatment option for her? I'll let you guys read through those as I take a drink of water. So in the chat, let me know what you think you should do if MJ presented to your clinic. We have a very quiet group. I'm the least quiet person. So let's go through answers. So she's not going to get more ICPI therapy at this time. So you're definitely going to hold therapy, which puts you at answer C versus D. Most common in a patient like this who has rapid progression up to 50% of BSA and erythema and swelling, they're going to get admitted for some IV high-dose steroids. And at that point, I would say your best answer is going to be C, hold and admit for IV methylprednisolone. So she presents at clinic 1 week after discharging from the hospital. You have to do a slow taper. Slow, like I mean over 4 to 6 weeks. Guys, do not taper your steroids fast if your patient has an IRAE. Consult dermatology, like I mentioned, Oncoderm is great here. She's going to continue all of those and any appropriate prophylaxis meds if applicable. Case 2, hepatitis. BG is a 50-year-old male, no significant past medical history with the exception of PD-L1 positive metastatic gastric cancer. He's on FOLFOX plus trastuzumab plus pembrolizumab, and he presents to the ED after his 4th treatment complaining of fatigue, nausea, and abdominal pain. What the assessment is, physical exam, yellowing of the sclera. Lab values reveal the following. So if you're looking at the ALT and AST, ALT is 5 times upper limit of normal, and the AST is 10 times upper limit of normal. Bilirubin within normal. How we treat hepatitis, right? You got to grab those labs and look at them. So because he was 5 to 10 times upper limit of normal puts him at grade 3. So in that setting, you're going to hold immunotherapy, initiate prednisone 1 mg per kg per day, Consider hospital admission, although I have done successful tapers with or successful steroids for hepatitis. Um, if the LFTs behave and they bump down appropriately with close follow-up with us. Monitor liver enzymes every 1 to 5 days. Difference between that and grade 4 is you're going to monitor more frequently. Usually a grade 4 is admitted. With this, if there's no improvement with steroids, you can consider adding a steroid-sparing immunosuppressive therapy like mycophenolate, for example. Your biologics like infliximab should not be used. So, according to those guidelines, which of the following best describes grade 3 ICPI-induced hepatotoxicity? How should you treat this therapy? I'll let you guys read through those. Yeah, B, great answer. That's exactly what you should do. Hold immunotherapy and start corticosteroids. D is not the correct choice because technically grade 3, you don't have to permanently discontinue it. So excellent job, guys. So yeah, grade 3, holding immunotherapy, initiating prednisone, monitor LFTs every 1 to 5 days, and then a slow taper over 4 to 6 weeks. Some patients get admitted with a grade 3. Some patients don't. I think if there's really close follow-up and you're following those labs and doing a slow taper, it can be done outpatient. But if those LFTs go through the roof, usually patients are admitted for IV steroids. Okay, so ICPI case number 3. So this was an actual patient case, and I think it highlights a more rare side effect from these. So this was actually my patient, a 32-year-old female. She had stage 3B triple negative breast cancer, and this was in 2021. She received the keynote regimen, right? So carbotaxol, AC, and pembro, followed by a mastectomy. Received cycle 12 of pembro because we do a full year of pembrolizumab for patients. Beginning in September of that year, all of a sudden there was an increase in her phone calls, nausea, abdominal pain, no diarrhea. We trialed things, PPI, H2. We did a CT scan that was negative. We got GI involved a month later because the symptoms just weren't improving. It was really odd. Colonoscopy was negative, H. pylori negative. Follow-up PPIs, all sorts of things. Nothing was really working. Finally, she went to the ED a month later because she had continued nausea, vomiting, inability to eat. So all of a sudden, she couldn't tolerate food. She was stabilized, electrolytes were normalized, did do an EGD consult that was expedited, which found autoimmune gastritis. So patient continued nausea, vomiting, inability to tolerate orals after this EGD, significant weight loss. So in this setting where we were going for cure for a patient with breast cancer, where after mastectomy, she should be recovering, feeling better. It was the exact opposite for her. Based on this information, right? Autoimmune gastritis, significant weight loss. What do you think we should do for the patient? And this is a really good discussion point once you guys read through the answer. And there can technically be more than one answer, so don't stress if you're like, I don't know which one she wants. Yeah, C or D. Great discussion point. So for this patient, you need to admit them due to this significant weight loss. She was almost starting to look a little cachexic, inability to tolerate orals. Admit, treat with IV steroids. Now, this would be a good patient that could support doing initially a 2 mg per kg IV methylprednisolone just based on how she was coming in and her having these non-specific symptoms for 2 months, where you can start high, so 2 mg per kg. If she starts to improve in a couple days, you can quickly taper down to 1.5 or even 1. So in this patient setting, I would support, if I was verifying your orders, I would support a 2 mg per kg on that one just because of the severity of her side effect. And it went undiagnosed for so long because gastritis is not common at all. So she was admitted. She started IV methylprednisolone 2 mg per kg, all the supportive care meds. She had rapid improvement in her symptoms once she started on steroids. She was discharged on prednisone after that. This poor woman required a very, very significant slow taper. I mean, by 5 milligrams, like we initially tried like 10 milligrams weekly, symptoms recurred. You go back to that dose that they were controlled on, and then we did 5 milligrams weekly, a taper by. Thankfully, we had to discontinue her pembrolizumab. I just checked in with Molly, the breast nurse. She still is without evidence of disease. So like she went through a lot, but she doesn't have any cancer, which is great. Again, this is a discussion point of this is a rare side effect, non-specific symptoms from a patient, right? There's a brief mention of gastritis in the SITC guidelines, and this is a really good example of a patient that required a long and slow taper. Okay, last case is colitis. Colitis, I would say, is almost like the second most common, third most common that I see for patients. Again, derm being the most common side effect. But JT is a 7-year-old male with DMMR metastatic colon cancer, treated with pembrolizumab every 3 weeks. He calls the on-call fellow, reports an increasing in bowel movements over the past 3 days. Baseline is 2 per day. Now he's up to 10 per day. He's had increasing amount of blood and mucus from his rectum and abdominal cramping. Now, I included that because in DMMR metastatic colon cancer, that can happen for patients once the immune checkpoint inhibitors are starting to work. That like blood mucus can happen. But for him, he had an increase in his bowel movements, which is then what triggered, when I was looking at notes, the on-call fellow then sent the patient into the ED. But if you're looking at this, went from 2 per day to 10 per day, puts him at a grade 3. So we need to know the stools, number of stools, every patient's favorite topic to talk about in order to grade it appropriately. So colitis management, globally, you have to rule out infectious, pathogens. So C. diff, that GI pathogen panel. More, grade 1, also looking at what the dietary looks like, making sure patients are hydrated. Grade 2 is when you initiate steroids, so 1 to 2 mg per kg. If no response after 3 days, and if your scopes are showing anything, that's when you can see infliximab or vedolizumab. Grade 3 or 4, these patients are usually admitted using IV steroids because oral steroids, you're not sure. As Devin mentioned, making sure absorption happens. So IV steroids in those patients. For these patients in 1 to 2 days, if they're unable to transition to oral steroids, that's when you pull the biologics out. Now, this patient got sent to the ED appropriately, got admitted, started on IV methylprednisolone 100 milligrams daily, which was 1 mg per kg for him. C. diff and GI panel were negative. Flex sig did show ulceration. After 2 days of IV methylpred, patient's symptoms really did not improve, and it was still significant output. So at this point, I would say you're going to start to talk about biologics. So infliximab is our current inpatient standard, so 5 mg per kg. We're working on vedolizumab that is probably coming down the pipeline. Need to do ID screening. So in the guidelines, it says HIV, hepatitis A, B, and C, and TB blood test. Now, you prefer to grab those prior to the first dose, but in urgent cases, that does not need to be resulted before you give a dose of infliximab. Depends on the stability of your patient. If they're not stable, you can give it. If they're stable, wait for those to come back. Duration of therapy is really not defined for biologics. They recommend maybe 3 doses, has been found to have less risk of recurrence. So a dose at day 0, and then at outpatient, you would get week 2 and week 6. And then you attempt to taper those steroids a little faster in those patients. So taper over less than 2 to 4 weeks to reduce the risk of complications of infection. Versus if a patient did not need a biologic and was on oral steroids, you're going to be tapering over 4 to 6 weeks. So with that, my final thoughts. Now, we use immune checkpoint inhibitors in combination with chemo often, and using dexamethasone in those plans. Very interestingly, some dex was included in studies, others not really. The effects are not known. NCCN guidelines, it says maybe caution, but we don't know. UW, we actually have a project this year. It's one of our resident projects, which is really exciting, to try to reduce the use of steroids in these chemoimmunotherapy plans. I think it's a good project to hopefully help to improve outcomes. Drugs, supplements, herbals, there's a lot we don't know. I always say caution to patients because we don't know the effects of these, and I don't think it's ever going to be something that's studied. It is challenging when ICPI therapies are combined with either TKIs or chemotherapy and trying to piece together when patients are having symptoms and what agent might be causing what side effect. Now, how we have things built here at UW, because if you look at certain immune checkpoint inhibitors, you're going to notice some disease states have preferences for what immune checkpoint they want to hear, but there might be a whole plethora of other ones that are FDA indicated. Our disease-oriented teams have the preferred ones built for their setting. With that, I'm 1 minute over. I don't have time for questions. That's okay. Feel free to shoot me an email, though, and always feel free to reach out if you ever have any questions about immune checkpoint inhibitors or any GI cancer patients. I am always happy to pitch in. So with that, thank you guys so much for being here at the beginning of your fellow lecture series.